That was a fantastic talk. Wow. I'm very pleased to be able to have such inspiring, illuminating colleagues to work with here. So let's see if I can bring the threaded case back. Okay, so we're going to buzz through case one. We know the AV is, again, my fault, not working. But we're going to fast forward in time. We're going to do a little sci-fi. We have that same 14-year-old soccer star who we saw with Dr. Che. We're fast forwarding into the future a little bit. Now they're 26 years old, training for a 5K, trying to keep those healthy habits in, finished undergrad, working the first adult job, developed a headache during a run, and then it worsened after the run. And it was crescendo building, worsening over the next 4 days. Features that are reported. Again, this is a call from the emergency department, whether it's in the afternoon, whether it's in your outpatient clinic. You're not there, you're getting this tale from the emergency department physician. They're saying there's slurred speech and confusion, which has resolved by the time that the patient has gotten to the emergency room, but it was what caused the patient to go to the ED after 4 days of having a headache. Reported photophobia, phonophobia, nausea, 10 out of 10 headaches. The patient has been taking over-the-counter medications, alternating acetaminophen and ibuprofen every 6 to 8 hours for the last 2 or 3 days prior to coming to the emergency department. Again, this is the same patient that we had from before, the theoretical patient who was the 14-year-old soccer star who had concussion with posturing during the game. Adolescents riddled with headaches, episodic headaches, not really followed up at that time, but just sort of ate over-the-counter medications. This is not an atypical story. We've all, if you see patients who are in this age range, who have this history of concussion and headache, this should feel somewhat familiar or potentially resonate with us. So this is the next best, this is a question about what would you like to know, further features, either historical or exam features. And again, the sort of tongue-in-cheek joke here is this is the phone call from the ED. So we're going to ask the audience at home to use the chat function to chime in, or audience here live to say, just shout it out. I'm an informal speaker, so I'm happy to repeat into the mic what people say. What do you want to know, either exam or history-wise, about what's going on with the current patient's headaches?
Does he have a history of recurrent headaches?
Yes, this is the same patient from before. If folks at home were not able to watch the threaded case from before, this is someone who had a concussion at about age 14 and had headaches that were episodic, but never had formal follow-up with neurology for a chronic, long-term headache management. So these are recurrent headaches, but this is the worst it's ever gotten.
How long did it take to reach 10 out of 10 intensity?
Excellent question. So how long did it take to get to 10 out of 10 intensity? Was it an acute onset or was it more insidious? The patient reports to the ED provider. It started during the run, it got worse after the run, and over the next 24, 48 hours, it really escalated to that 10 out of 10. So it was not an immediate kind of thunderclap type headache, it was more of a build over the course of several days. Yes?
Online, I think they're asking positional or postural component.
Positional or postural component. Right now, again, you're getting a call from the ED provider. Well, they're laying in their bed and they said their headache is still bad. So that means they're not going to go back in and check because they don't want to call you back because they've got you on the phone now and they've got 3 other patients who are demanding narcotics in the ED. Again, real world. I'm giving you the real world answers. This is not the ideal hermetically sealed version of a test. All right, I'll move on here. Oh, did somebody raise their hand in the back? Yes.
Is this the first episode, the first during training?
This is not the first training headache that they've had, but typically when they rest after exercise, and I'm glad you brought up the exercise-induced headaches, after those exercise-induced runs, this patient will sort of calm down, drink ice water, lay down, ice pack on the head, take an over-the-counter med, and it goes away.
The first episode of 10.
This is the worst they have had in their life. Yes, this is the worst she's reported. All right, so again, similar questions before. I'm going to ask our experts to chime in after we kind of go through the options here. So option number 1, give them some IV medication, reassurance. These are just headaches. Come see me in my office on Monday. Raise of hands for that. No one's biting. Okay, I guess my trap answers are failing here. CT head non-contrast, show of hands. All right, a little bit more action on that one, a lot of bit more action on that one. Lumbar puncture, does anyone want to get a lumbar puncture on this patient? Dr. Charleston effectively dissuaded most of you. Some people still want to get the lumbar puncture. Excellent. What about the MRI of the brain with and without contrast? We've got at least a handful of people who want to get the MRI, or none of the above. And if there's any none of the above, if you want to shout it out, I'll repeat it into the microphone. What would you like to do?
CTA of the head and neck.
CTA of the head and neck. Yeah, absolutely. All right. So I'll ask our experts to sort of weigh in. What are your thoughts on what would you do for this crescendo headache? 4 days, progressively getting worse. What's the next best step here?
Yeah, I think that we absolutely have to get imaging. I like that CT of the head and neck. The CT is just something that's fast. If I can get an MRI, I mean, so I'll tell you what I'm thinking. I'm wondering if something happened. If they've never had a 10 out of 10, so now this is their worst headache in their life. So, although I will say that I counsel patients that if you don't have a 10 out of, I counsel patients on the severity so that we really can understand each other. So 7 is severe. You tell me you have a 7, I believe you. It is severe. 8 is so severe you can't do anything. 9 is an emergency and I'm looking for a bleed in your head. So, and then 10 is unconscious. You couldn't even tell me. Somebody has to call, or the emergency department has to call, as in this case. And so I would definitely, just to kind of put a perspective so that we can communicate. Otherwise, if everything is severe or everything is not severe, I mean, we just need to be able to communicate. And so, yeah, I absolutely. So I'm thinking like, I want to rule out secondary headache first. You know, if they've had a history of, usually headaches with exertion, I mean, it doesn't last that long. So something is a little bit different. If we think about our Snoop mnemonic, this is pretty new. This is different. And so I definitely want to get imaging with this. There are people that have phenotypes, so if they need a diagnosis. So if they have because this could just be status migrainosis, but that's a diagnosis of exclusion, right? Status migrainosis is going to occur technically when the head pain lasts more than 72 hours. And so there are people that that's what they have, that's what they live with. But if this is the first instance, I can't diagnose that on the first instance of this happening. So yeah, I would definitely work it up a little bit more.
You're picking up everything I put down. Thank you. Dr. Che, any other comments on this case?
No, I agree with what's been said and what you guys voted on. Like my caveat though is that there's an entity that happens in kids quite frequently where they will have a bad headache and it just doesn't go away, new daily persistent headache. And so the severity is something different that tends to be less severe. But this kind of persistent headache for me doesn't, in that pediatric population, if I'm getting a good exam, doesn't necessarily mean I'm jumping to imaging. And I think the other thing that I want to know, being a sports neurologist and taking care of athletes, is are you hydrating enough? So those are, I think, keys for me, especially in my adolescent population. They're never drinking enough fluids. And so I think those are just some additional things that I want to know or, chime in on.
Yeah, these set of questions might be frustrating to people who want like there to be a correct test answer, but this is very rooted in real world, and the lack of hydration in someone training for marathons and 5Ks in sport is such a real counseling and patient education moment that I'm glad you brought that up. All right.
Yeah,
so,
and then just one thing.
Please.
This patient, needs a diagnosis, because now we can work and now we can do if we want to do seeds or different lifestyle things, and absolutely, because this patient needs a diagnosis so that we know what we're working with, and so we can adequately treat and counsel.